Assalamu alaikum. This is Dr. Shafiq Cheema. Today's topic is very important, and this one is for all the nephrology fellow practicing physicians, all the people practicing nephrology, cardiology, assistant professors, associate professors of medicine, as well as professors of medicine, because this is an important and to some extent controversial topic. And this lecture is being recorded in March 2022. So we have all the major trials. We will be talking about intensive blood pressure control in diabetics. Should intensive blood pressure control be targeted, in which systolic blood pressure is brought to less than 120 and diastolic 80 or less? The current American Heart Association guidelines tell us that blood pressure should be less than 130/80. And in 2015, another major trial came, which was sprint trial. The sprint trial basically had formed the basis of the new guidelines for blood pressure. Blood pressure, according to JNC8, used to be target blood pressure should be less than 140/90 in all the ages. But now the target has been decreased, and that was after sprint trial, because sprint trial actually favored the intensive blood pressure control. In sprint trial, they had not included the diabetic patient, and they took the patients with the additional cardiovascular risk factors and separated them into two groups. One group, the targeted blood pressure was less than 140, and the other 120 or less. So obviously the group in which they targeted blood pressure 120 or less had more side effects like hypotension and acute kidney injury and hyperkalemia. But overall, it showed a significant benefit in all the primary and secondary outcomes, including mortality, acute MI, cardiovascular disease, strokes, and everything. So after 2015, when the new guidelines came, I think around 2017, the target was dropped from 140 to 130 based on the results of sprint trial. But sprint trial did not include the diabetic patients. Also, we also have some evidence that people with polycystic kidney disease who have chronic kidney disease, targeting blood pressure to less than 120 benefits the progression of polycystic kidney disease and chronic kidney disease. So today is a very specific question, because most of our patients who have kidney disease or don't have kidney disease, along with diabetes, they have some, along with hypertension, they have some evidence of diabetes. In fact, most of the diabetics are hypertensive. So what happens in diabetes, because a trial few years prior to sprint trial around 2008 was a big trial, a CORD trial, which was negative for benefit of intensive blood pressure control. So let's review what is the situation in diabetics. So many years ago, there was a small trial called ABCD trial, which showed intensive blood pressure group, in which they tried to target at that time 128/75 versus moderate or standard blood pressure group did better. The intensive blood pressure group has less reduction in GFR, meaning worsening of kidney disease was less in intensive group as compared to standard group, and also progression to microalbuminuria, macroalbuminuria, nephropathy, retinopathy were all better in intensive blood pressure group. But this trial was many years ago, and there was some criticism on it. It did show some cardiovascular benefit too in people with peripheral vascular disease. But the main trial, which was published in around 2010, a CORD trial, this was to see the effect of intensive blood pressure control in diabetics. And many people thought it's a negative trial, meaning it did not show benefit. I'll try to show you that this trial was also positive trial. It did show benefit, just like sprint trial, in which they did not include diabetic patient. And then we will make our recommendation. So this is what they try to do. In the intensive blood pressure group, they try to achieve blood pressure around 120, and in the standard around 140. And you could see intensive blood pressure group, they use around 3.5 medication, and in the standard 2.2 medication. And then the primary outcome, non-fatal MI, non-fatal stroke or cardiovascular death, there was only 12% reduction. For it to be significant, they wanted to have around 20% reduction. So they said there is no benefit except in cases of non-fatal and total strokes. There was benefit in the intensive group. But if you see, it has two standard and intensive glycemic arm as well. So the standard arm was doing better as compared to intensive glycemic arm. And as we know, if we try to achieve hemoglobin A1C of 7%, but if you try to achieve lower than 7%, like 6%, the mortality and the risk of complication increases because myocardium and myocardial cells cannot withstand ischemia in the setting of a low glucose level in them. So in this trial, they tried to achieve in the intensive glycemic arm probably hemoglobin A1C around 6%. And when hemoglobin A1C dropped to 6.6%, the mortality increased. So they have to terminate the intensive glycemic arm. This is how it was. This is the intensive glycemic arm and this is the standard. So if we exclude this from the blood pressure trial of this arm and just take the standard glycemic arm. So people have shown, like Leo Buckley have shown, if you just take the standard glycemic arm and imply intensive blood pressure control, the benefit of intensive blood pressure group would be the same like sprint. All the bad effects have been because of the intensive glycemic control. So they said, there is no difference. And they end up concluding that intensive blood pressure control reduce the cardiovascular outcomes as long as you apply standard glycemic control, because intensive glycemic control had bad effect in this accord trial. And similarly, there was another study in which they just took standard glycemic control patient. The groups were kind of similar and they showed the same thing. The results in the accord blood pressure with standard glycemic control are similar, just like sprint trial. You would see a benefit in the intensive. But if you have combined glycemic control, there would be no benefit. So it's the glycemic control, not the blood pressure. Same is true for mortality. And also, then they also try to see when they have a composite endpoint, and then they terminated the intensive glycemic control. And when they followed those patients, look at the line, intensive blood pressure control started showing benefit. So I'll make it very simple. If you have a standard glycemic control, HbA1c target 7%, as most of the guidelines suggest, the intensive blood pressure control, even in diabetics, is beneficial. So they end up concluding the effect of intensive blood pressure control on cardiovascular events and all-cause mortality were similar in patients without diabetes as well as with diabetes. There must have been an interaction between intensive systolic blood pressure lowering and intensive glycemic control, which led to a poor benefit. But there was one criticism that there was more fall in GFR to less than 30 in the intensive. But at the same time, the number of dialysis patients were the same. Like even if the low GFR is less than 30 in this group, but almost same people reached end-stage renal disease. So this was not significant. This was probably the hemodynamic effect, because there was another study in which they checked the 4 kidney markers in people who had reduced GFR to see what happens to them. And they found out if you have intensive blood pressure control versus standard blood pressure control, intensive blood pressure control had more fall in the renal biomarkers. So the effect on the fall of GFR or increase in creatinine is hemodynamic effect. It does not actually cause kidney injury. So kidney injury chances did not increase with intensive blood pressure control. So if I summarize, I could tell you that accord blood pressure standard glycemic arm, not the intensive glycemic arm, showed reduction in cardiovascular events and all-cause mortality similar to sprint. And treatment-induced creatinine elevation with intensive blood pressure control are not associated with intrinsic kidney injury. as I showed you, if you check the acute kidney injury marker. And this effect is similar to ACE inhibitor and ARB and SGLT2 receptor antagonist. It's a hemodynamic effect. Once you stop it, creatinine goes back towards normal or GFR increases. So if you don't want to see your patient with increased cardiovascular events, mortality and worsening kidney injury and albuminuria, then you should target intensive blood pressure control, even in diabetics. Remember, in non-diabetics, SPRINT trial has confirmed and basically concluded that intensive blood pressure control is better. That's why American Heart Association guidelines have changed, dropping from JNC 8 blood pressure target of 140 to 130. The evidence was so convincing because these guidelines came in 2017 and SPRINT trial came into 2015. Before that, in 2008 or 10, when the CORD trial came, JNC 8 came, the blood pressure target was high. So I could conclude, if you have a non-diabetic patient, try to achieve target blood pressure 120 or less. If you have a diabetic, you could achieve that as long as you're not trying for intensive glycemic control. Just go with the standard KDICO, American Diabetic Association guideline of HbA1c of 7%, and you could try to reduce their blood pressure to around 120, or based on the guideline, maybe 120 to 130 would still be better than 140. And you would have benefit in terms of cardiovascular disease, ischemic heart disease, MI, heart failure, mortality, with some increase in the side effects in terms of hypotension, acute kidney injury, and hyperkalemia. But these side effects did not lead to any significant outcome in terms of development of end-stage kidney disease and all that. So this was very important and relevant for the people who are practicing, and I hope I was able to clarify my point of view about intensive blood pressure control in non-diabetics based on the SPRINT trial, and in diabetics with standard glycemic arm in a CORD trial. Thank you very much. I hope you liked it.